Welcome everybody, and I'd like to thank the Colombian Society for inviting me, particularly Alejandro and Carlos. Thank you very much. It's a huge privilege to be here from the UK. So because I don't understand anything that's said about me, I'm going to explain to you who I am, because my Spanish unfortunately is limited to 4 ham and cheese sandwiches and 4 beers. So I don't understand anything. So I'm a physiotherapist from the UK. I also qualified to give lectures at degree level. I have a book which I'm going to show you in a second. It went to #1 in the UK, which I'm very happy about. And the London Marathon, one of the biggest running events in the world. I'm the official physio for that marathon. I teach shockwave, both up and down the UK and also worldwide. I spent 16 years in a canoe, piragüismo, going up and down all around the world for 16 years, racing for my country, and I've started and created many physiotherapy clinics and then sold them, and I work between where I live near Newcastle in Hexham and also in Harley Street, possibly one of the most famous medical streets in the world. I also presented this year at the ISMST in China, which is a great moment for me and the UK. So, my book, which you can see is translated into Spanish, so I've brought that cover for you, is all about running injuries. That's my specialism, is running injuries. And some of my talks later on today will be specifically about that, and the use of shockwave. In my daily career, I will see 14 patients a day, and at least 10 of those will receive shockwave therapy. I'm probably the most prolific user of shockwave in the UK at the moment, and I use both radial and focus shockwaves regularly. So I'm going to talk to you today about trigger points and myofascial pain syndrome. So this is going to add a little bit to the talks that we've had here today, because I'm also going to teach you about some fairly new applicators that you may or may not have seen before, which have been very, very useful for me in treating athletes with myofascial pain and of course trigger points. So we won't spend too long talking about the definition, because you've had it already today, but a trigger point, which is the primary thing, is defined as an area of muscle, painful to palpation and presents with a tight band, whereas myofascial pain syndrome is a series of sensory, motor and autonomic symptoms caused by the stiffness in the muscle, caused by the hyperirritable nodules in musculoskeletal fibres. So, this is a picture which we've seen already today, but it's interesting to understand that how this trigger point is present in some of the fibres, but not all. This is the healthy fibre, and here we have some trigger points. So let's talk a little bit about what they are. So, in the event of a muscle injury, we get dysfunction of the neuromuscular end plate. We get this increase, as already been spoken about, of acetylcholine and the synaptic gap. And this triggers then the miniature end plate potentials, which causes depolarization. That then causes an increase in calcium within the retinaculum, which produces a sustained myofascial contraction, and this is what forms the knot. This knot then compresses on the vascular capillaries, which causes ischemia and hypoxia, that loss of oxygen. And we end up with a local energy crisis. The ischemia sensitizes the nociceptors through the release of inflammatory mediators and a local sensitization to pressure. So we can see it here, you've seen this slide already, but this is where we get the excessive release of acetylcholine, we get the depolarization, we get the calcium release, and then the sarcomere contraction, which then increases the energy requirement, but the vascular compression causes ischemia, hypoxia, and reduced energy supply, which creates this energy crisis. That then creates inflammation, it creates the muscle nociceptors through sensitive speed, and the no uptake of calcium into the cytoplasmic retinaculum causes our trigger point. So it's important to understand this cycle if we're going to understand how to break it. So how do we break it? So the mechanisms of shockwave treatment, we establish a mechanosensitive feedback loop between the acoustic impulse and the stimulated cells, which then creates a specific transduction pathway and the gene expression. So mechanotransduction, which we've already heard about, causes an increase in perfusion, which promotes angiogenesis and alters the pain signalling. in the ischemic tissues, which is caused by the influx of the calcium. So we have a very positive effect already. Then we get the reduced nerve signaling. The free nerve endings degenerate after the application of shockwave by bringing about the degeneration of the neurotransmitters at the neuromuscular junction. So we have reduced pain again. And then the greatest factor possibly is the fact we can use shockwave to break up these links that we do not want within the active myosin, which are running perpendicular to the sarcomere. So, also to talk about the gastrocnemius and the calf muscle, we find that combined shockwave to the plantar fasciitis and the gastroc and soleus gives us a much better result than just using shockwave for plantar fascia. So again, in some of the most common indications that we would use shockwave for, we find that applying also some trigger point therapy actually makes the treatment far superior. So let's look at some equipment and some protocols. So this is the periactors, where you can actually apply these via a small clutch adapter to the radial devices. And these are fairly new. I've been using them for some years, and I use these, as you'll see shortly, in helping me alongside giving shockwave through the radial and focus device in order that we can help to improve the trigger point. And then we have these spine actors, which work on the paraspinal muscles. And it's great that Thomas was showing us just quite how important it is to work on the paraspinal muscles and to work on the myofascial release there. So you can see these now in action. We're actually using these on the spine, so you apply a little bit of gel, and you have a 45-degree angle, and you work over a small section, maybe 2,000 shots over this small part of the lumbar, and then you move up higher and repeat the process. So we have applicators for the lumbar spine, the thoracic spine, and the cervical spine, so we can get the whole spine involved. Also, indications for our athletes, we have the gluteal muscles, trapezius, around the scapula, the gastrocnemius, TFL, tensor fasciculate, and the iliotibial band, and also in the forearm, where we can use this next applicator, which are the more like used as a massage tool. We use these actually, I use them to locate the trigger point, as you'll see from my video. So this one is using the scraper, and it's a bit like using those sticks where you walk around to find water. I'm using it not only to treat the myofascial tissue, but also to help with the patient interaction, to actually locate the trigger point. As you see working down through quadratus lumborum, not only does it work in the paraspinals, but it helps me to find the trigger point, whereupon I can change the adaptation to one called the sphere, which is specifically used for trigger points. I've already isolated where that's going to be, and then I use that treatment on there. So when can these applicators be used? So we're talking about for athletes. So I use them as part of a treatment protocol, and I'll share my exact protocol with you very shortly. Or we can use them in isolation, but we can use them in the injured athlete. We can also use them to aid performance, so as part of a maintenance program, and also use them in pre-event, so we can actually help to lengthen the muscle tissue, reduce the likelihood of injury. But remember, with these applicators, we are using the radial shockwave device, but we are not actually emitting a shockwave. It is a pressure wave for sure. And then post-event, we can use it for recovery, but also to do regular MOT treatments to aid with the recovery and the maintenance of the athletes. So they form part of the whole process that we use with our athletes. So my protocol is such that we would use radial shockwave for medium-sized muscles on about 1,000 pulses, 1 to 1.5 bar, and for bigger muscles, you would increase the bar pressure. Thomas Zadelka mentioned about the obese patient. It is my very, very strongly held belief that you need to think about the larger patients. Perhaps I'm not working with obese patients, with athletes, but athletes who have a huge amount of muscle tissue, where they work very, very hard and they have a lot of hypertrophy. We have to think about possibly increasing the bar pressure and maybe decreasing the hertz to achieve the greater depth. And by changing the applicator to a deep impact applicator, again further increases the depth. So this is for guidance. Really, you want to be treating your patient and looking at your patient and identifying what is needed, what is the depth that you want to get to, and therefore what applicator, what bar pressure, and what hertz. I believe in treating the patient, not just using a protocol the same for every individual. So over 12 sessions, we can maybe do 3 times a week. With the athletic population, I think you can do more. So I might start with the V-Actor, which is a massage device, and maybe 3,000 pulses. You can use 2.5 bar, no problem, and very, very high hertz, like 20 hertz. This helps with the hyperstimulation anesthesia, so it reduces the immediate pain response. Then we can use a periactor, which I showed you in my short video. We're actually looking to work on the muscle tissue a little deeper, but also using it to try and find our trigger points. And then we can move to the sphere, which you saw at the end, and to actually work directly on the trigger point. This prepares that area, and it makes it very nice for the patient because you've created that hyperstimulation anesthesia, so they feel a lot less pain. Then directly over the trigger point, you move to your radial device and actually produce the shock wave, maybe 12 to 14 hertz. If you have an athlete where they have a very low body fat, then you want to increase the hertz so it reduces the pain. And you work on your bar pressure, 2.2 up to 3, 4, 5, dependent upon the patient's response to the pain. So you're constantly asking the patient, what is your pain out of 10? And our aim is to get to 5, maybe 6. The whole muscle group can also be treated with the radial shockwave, and we can do, again, 2.2 bar plus pressure. So it's quite a long treatment going from the V-Actor through the periactors into the radial shockwave. And if you use focus shockwave also, you can then go directly to the trigger point. This is to show you another protocol where they combine shockwave treatment to the trapezius, but also stabilization and shoulder exercises. And one significant theme I hope we'll see, certainly through my talks, and we've already heard today, is that combining shockwave with exercise is the gold standard. I think that what we do is we create an opportunity for tissue healing, but moreover we create an opportunity where our patient can move, and we need to teach them how best to move, and that is the best type of exercise for them to get to their end goal. And if we're working specifically on the patient, then we should be thinking about how they will do their homework in between coming to see us. 30 minutes in my company is not enough to treat the athlete. We need to make sure that they are doing stuff every single day to help themselves. So this book has already been shown to you. I think it's great further reading. I think it's something that if you haven't already got and you want to work with myofascial trigger points and soft tissues, this would be the go-to Bible. So treating the spine, as we already showed you, this is just to show how I would teach it. So this is me actually in a lesson in the UK last month. So I don't know if you can hear the volume, but I'm saying you can feel the tension, and you can actually move side on to work on the facets themselves. And we create a little bit of depth here, because we're trying to get through the superficial muscle tissue into the deeper tissue, maybe even having an effect on the multifidus. But we can work 2 facets at a time, and we can also work either side of the spine like so. It's a very, very effective treatment, and actually, if we had the ability to do a demonstration later, I'll be able to show you even just a forward flexion on anyone in the room, and we could do this treatment, and then we show that you have greater forward flexion straight afterwards. Just showing you here that you must apply the gel, and if you don't apply the gel, then unfortunately the skin will have a reaction to it, and that you have reasonable pressure, but you don't try and push this all the way through to the belly button. That's not comfortable for the patient. So thank you very much for listening, and hopefully we'll look forward to some questions afterwards. Thank you very much.